Hello, everyone. My name is Dr. Amir Abbas, and today we have with us Professor Saeed Akhter. He's a transplant urologist. He's a public health professional, had been associated with several national and international medical institutions. Some of them are the leading, not only the leading institutions of Pakistan, but also the leading universities of the world. That include in the past the Shifa International hospital, and he had been associated with the University of Minnesota, Maimonides Medical Center in Brooklyn. If I'm just pronunciating it right, I will ask Dr. Saeed Akhter. He has been
Maimonides.
Maimonides. Okay,
Maimonides,
yeah,
right.
Maimonides, and then Yale University, and there are a long list of publications to his credit. He has around 80 publications to his credit, and currently he's the chairman of board of governors for Pakistan Kidney and Liver Institute. And I know that he has also been the founder of this institute when this institute started way long. And before we start the conversation, Dr. Saeed Akhter, I'm sure that so here's my problem when I talk to people like you. It's very difficult to keep the introduction short, but at the same time, do not miss anything. So, is there anything which you would want to mention as part of your introduction, with which you
Well,
want to identify
yeah.
yourself?
The only thing that I want to add is that I have a shell of a surgeon. I'm a urologist and a transplant surgeon.
Okay.
But at my core, I'm a public health person. And that's wherever I work or whatever I do, I always ask myself, what would be the broader impact of anything that I do? Realizing that we live in Pakistan and serve the people of Pakistan, I think it is extremely important that on one hand, we should develop our tertiary care hospitals, transplant programs, sophisticated cancer treatment hospitals, but at the same time, I think our focus should be on the prevention of the diseases. So we've been working for a long time on prevention of kidney disease and now the liver disease since I've taken charge of PKLI about 8-9 years ago. This is where I think I need to emphasize.
Right. So that is exactly we have you on our on this channel today to have a discussion on the role of AI in public health as well as in clinical care. The title is, and that's exactly the reason because I'm aware and that you have a background of a clinician, and even before that, like you talked about surgeon, but before that, you're a medical doctor and a surgeon, and then a public health professional. And I also know that you value the role of data a lot in different public health as well as clinical decision making processes. And AI is a recent boom, so we're going to talk about that a lot. But just to set stage for a discussion, would you like to tell us a bit about Pakistan Kidney and Liver Institute, and in addition to that, hepatitis prevention program in Pakistan?
Right. So basically, 38 years ago, when I went to United States, my first place of landing was at Yale University in the School of Public Health. I was fortunate enough that the program I was in, we also had a lot of hands-on research experience, like growing my own cells, creating monoclonal antibodies and polyclonal antibodies, doing a lot of different basic molecular biology techniques. So that exposure of Yale with the public health issues and how they address at Yale, we had the WHO serum reference bank. So anywhere in the world there was an epidemic of any disease, they would deposit the serum at the Yale serum reference bank. And maybe 20 years down the road, at that time, it may be an unknown infection or something that we did not know. But down the road, as the diagnostics come into the picture, we knew that, for example, Congo Crimean hemorrhagic fever was one of the things that was discovered over there, et cetera, et cetera. So when I moved on and I wanted to become passionately a surgeon also, so I did my training in New York, and then I moved on I was a chairman of urology at Texas Tech University Hospital, did a transplant sabbatical at University of Minnesota. And then in this whole maneuver, I got a chance to see a lot of good institutions. I spent 3 months at Harvard in basic lab, Center for Blood Research, and Dana-Farber Cancer Center. So I always used to think that, if I can do these things in America, why can't these things be done in Pakistan? So that was one of the reasons for me moving back to Pakistan, besides some other family reasons, was that I wanted to create a center of excellence in Pakistan, which can match any good center in the world, with a very clear understanding that these centers are not built overnight. Take the example of Hopkins, started from 1898, 1889. Now it's almost like 150 years. Uh, Harvard 500, Yale 450 years, Oxford 800 years. But somebody has to lay the foundation somewhere. And that's how I felt that when I come back to Pakistan. And that was the vision. That, so every time I went to the best institutions, I traveled to best institutions just to learn, either to give a lecture or to listen to a lecture or to do a surgery or to observe a surgery. I always took notes in my mind that if I God gives me a chance that I should create something in Pakistan, what should be the blueprint of that organization? And that's how. So PKLI was, even though we laid the foundation in 2014, but this whole process started almost 30 years ago, 25 years ago, when I was sort of looking at different institutions, what are the systems, how the system works. If I can tell you what is the strength of the West in one word, it is the systems that they built, be it research, be it their epidemiological programs, be it their surgical programs, be it the hospital management, be it the overall healthcare system. It's a system that actually works, and it's a success of the system that why West is so successful, and unfortunately we are not. And the idea behind creating PKLI was that we should create a system-based organization, not just, if I'm there, the organization works. If I leave, the organization dies. So Alhamdulillah, we have put in the laid the foundation of a very successful organization, which is all system-based. We chose Joint Commission International as our benchmark for quality, which again I adhere very closely. We want to make sure that whatever we do according to a system. We follow some policies and procedures, and nobody has to do a sifarish, or somebody has to say that some so and so is in the hospital, please look into it, because our system prevails and things are automatically done like we did in the West. So this is the background of. So when I came to Pakistan in 2000, I created an organization called Pakistan Kidney Institute, PKI, which had been treating a lot of poor patients. And in 2014, when I met the chief minister of Punjab at that time, he invited me to come to Lahore and add liver into the picture, because he had been spending a lot of money to send people out of the country to do the liver transplant. So he wanted me to. So that's how we laid the foundation. We add liver into PKI, so it became. So PKI was the precursor molecule of the PKLI that we had been working for almost 14 years prior to the formation of PKLI. And when I joined PKLI, one of the things that shocked me was the amount of disease that existed in terms of hepatitis C, causing almost 90% of the burden of end-stage liver disease, uh, cirrhosis, liver failures, etc., and cancer. So that's where the epidemiologist from inside me woke up, and I said, nothing doing. We will be doing transplants. We'll be the center of excellence in the clinical care. But our one of the missions. So there were four specific missions of PKLI. One was the prevention of diseases like kidney diseases and liver diseases, including elimination of hepatitis C. Then the second was excellence in clinical care, like doing the best transplants, doing the most complex cancer surgeries that we are doing, creating the best systems in the clinical works. And the third, but the foremost significance of PKLI was to create a university, just like on the pattern of some big universities that I had visited or I had studied in, creating center. And the fourth, but not the last one, was the research, because I strongly believe that till such time that we perform research and we combine the clinical and basic scientists together under one roof, like we had in USA, we as Pakistan cannot grow. It's absolute need of the hour. So these were the four specific purposes of building PKLI. And Alhamdulillah, we have already matured ourselves into the clinical care, and we just did celebrated 1,000 transplants despite 2 years waste in COVID. So we inaugurated ourselves in late December 2017. 2018, we started our clinical activity, but then 2 years were lost in the COVID. But despite that, we have done 1,000 live related kidney and liver transplants with excellent outcomes. We just launched the PKLI University. We also launched the hepatitis prevention treatment program through the platform of the PKLI. But to tell you that what made my dream come true was that I sort of requested the Prime Minister to launch a national campaign, not just Punjab-based campaign, for the elimination of hepatitis C, just like Egypt. And on 6th of August, we have done that. So this is going to roll a huge big cycle of a preventive program and a treatment program and diagnostic program, and we'll talk about that as we go further. So this is my dream come true in terms of creating a center of excellence. And obviously, this will not become Harvard of Pakistan in next 10, 20 years. It'll take maybe a couple of 100 years, but so be it. It's important that we lay the foundation and let the system grow.
Right. So, Dr. Said, you talked about a couple of things, and I want to go into a depth of that because that connects directly to our discussion about artificial intelligence. Yes, you talked about the clinical care. Obviously, that's important. You talked about the educational aspect, the medical education aspect. That's important. But one thing which I wanted to speak about is many, and I've, you know, that I worked with you, and I know for a few months, so I know when you say a system, how does that look like? But I want those who are listening to this or seeing this is that when you say that Pakistan Kidney Institute and Research Center is, if I recall,
Or
that
the
is the
Kidney and Liver Institute and Research Center.
and research center, right? Now, the thing which I want to ask you as a question as well as a point of emphasis that I've seen many hospitals that they will just like add this research center bit to them, just as a marketing stunt or stuff like that, but they are not actually. In a true sense, they are not an academic institution. They are not. They are just a bunch of clinicians collected together and just practicing under one roof, which I don't think is wrong. But I mean, you need to name things properly, right? So, what is your vision for a system, for a research system, and how do you envision of
Right.
actualizing that in
Right.
PKLI for generating quality data?
Right. So basically, I am a very clear-headed person because I spent 2 years in a basic lab. I'm one of the few surgeons, maybe the only surgeon in Pakistan, who actually spent 2 years in basic lab. Then when I went to Texas Tech and I was a chairman there, we had a very, very well-knit research center and research system. And our lab was like a $10 million lab, which had all the mice and the rats and baboons. So you name it, and we had it there, the animal lab. So I have the basic hands-on experience of the basic molecular biology lab, doing all translational kind of research, proteomics, genomics, as well as a hands-on animal research lab. So this is what we are going to create in Pakistan. And yeah, I mean, just to emphasize the point, I think your point is very well made. But I have a very clear vision that the gap, the biggest gap in Pakistan is that the clinicians are so busy and they have no inclination towards research, even though the institution may be called as a research center, that they never, ever, ever talk to a basic scientist. So here we are in this dilemma. There are a bunch of basic scientists who are sitting in their labs doing nothing. They have all the resources, but they don't have the clinical material. And here are the clinicians who have all the clinical material and the data, but they don't share it with the basic scientists. At Texas Tech University, we had a professor of biochemistry who's part of our faculty. We had a professor of physiology who was part of the faculty. We had a professor of pathology who was part of the faculty. And we interacted very, very closely. And this is the fundamental difference between PKLI and any other university that we're going to create, that our university will have a very strong uh, basic and clinical research. Similarly, so move on to the clinical research, a lot of centers We don't see a lot of clinical. There is some clinical research. There's hardly any basic research, even in the most top-notch institutions in Pakistan, from my perspective, as far as I can see. But there's some clinical research, but I think we need to go to a higher level. And that's where I want to emphasize your point that you mentioned earlier. And I have a very clear head about that is that data is future currency. I repeat, the data is future currency. So and unfortunately in Pakistan, we don't take care of our data. Our data is not well preserved. Our data is fabricated. Our data is concocted. So we don't have any faith from any of the people from outside the country that if they want to do research, where is the data? Where is the clean, credible data? And the only way to bring that clean, credible data is to develop electronic medical records that from day one we wanted to put them in PKLI, and so that we catch very clean data. And similarly, when we opened our hepatitis prevention and treatment centers, 23 centers across Punjab, we we custom made a software that catches the clean data. Just based on that clean data, Gilead contacted us. Gilead is a big multi-billion-dollar company. They wanted to do research with us because they knew that we'll have clean data, and we have the clarity of thought about the cleanness of the data. Similarly, Abbott, another big giant in diagnostics, they contacted us that they wanted to do some research uh, in core antigen, which is one of the diagnostics competing for a PCR to make a diagnosis of. So they wanted us to test their kit, etc., etc. So I think first thing always, Amir, is the clarity of vision. Everything else is secondary. If the vision is clear, things are easy. So Alhamdulillah, I have a very clear vision, where to go, what to do, and now we are putting things together. So we have just interviewed somebody from Aberdeen, University of Aberdeen, who will come as a director of clinical research. I've just interviewed somebody as associate director of basic research who has a lot of hands-on experience in CDC Atlanta with proteomics, genomics, running PCR, doing ELISA, doing all kind of a basic molecular biology technique. So we combined the basic research with the clinical research.
So, Dr. Saeed Akhter, I just want to uh, ask another question, which is just pertaining to another aspect of research management and uh, in some of the leading universities in Pakistan. Now, here is the problem which I have seen uh, is the vision of the research institutions in the leading universities is either maybe produce more publications or bring more grants. And I think you're nodding your head, and that's that means that you are well aware of what I'm about to say. But what
Yeah.
happens in that is like my local problems for Pakistan, like for example, that will not be, for example, I need to know what are the exact problems, what are the contextual problems of whether relevant for decision making in terms of hepatitis prevention program. What is the villager thinking? What is the barber thinking? And what is the other person thinking? So that, which means that a lot of data generation work, they may not be funded by international agencies, and they may not convert into a lot of publications. I mean, there's no harm in any one of them, but I'm not in favor of kind of like taking your strategic direction away from your main strategic goal. So what do you think about this point, like and
Right.
how
So,
you envision
so,
PKLI
so
research is about?
basically, I think publication and grants, they're
Yeah,
byproducts.
yeah,
They're
Brad
important,
Products.
but they're byproducts. That's not what we are here for. I always say, I've said this maybe thousands times, that uh, universities generate knowledge. Our universities don't generate knowledge. They just transfer knowledge in one form or the other. I've seen at Yale, everybody was saying, I'm making a monoclonal antibody against the project that I was involved. We were trying to make monoclonal antibodies against malaria, thinking that we can kill malarial parasites because the whole world, Africa, etc., very high burden of disease. One of my professor, Nancy Ruddle, she wanted to create a vaccine at that time for AIDS. AIDS was just coming up in 1985, and we were all very scared about it. So what I'm saying is that we don't make a single drug, we don't make a single molecule. That's not not my vision of research. We want to create our own centers where we should be producing our things. We should be generating knowledge, and that's not possible without doing a basic research. I'm very, very clear-headed person that unless, and then you start with one thing. For example, we are just about to start a collaboration program with University of Kentucky. What they are doing is they have figured out that they have figured out a method of extracting exosomes, which we at one time thought they were just appendigeal structures, 80 to 90 uh, micro nanometer. We thought they were just a waste house, floating debris kind of a thing. But now we know that these are the signaling pathways actually. And so they have devised a methodology where they know how to extract and then how to run chromatography to look at the different patterns of, and their interest with us is that we have a high volume transplant center, so they want us to collaborate with them to see what happens in early rejection before actually the creatine bumps up, what happens to the expression of exosomes. Similarly, they are also very interested, and I am also very interested in looking at the people who have developed Hep C, who develop HCC, and people who don't develop HCC. What's the difference? And we want to look at their molecular patterns and different genomic patterns and see what's the difference. So this is the kind of research we are talking about. We are not talking about. And then also I want to add, you and me being an epidemiologist, that one of the basic fundamental pillar missing in our country is a network of epidemiological centers or public health centers or places at district level or the headquarter levels connected centrally to a central agency like something like a CDC, that we don't have any surveillance mechanism. And I think that's another part of my mission. And that mission I will accomplish through this hepatitis C plan that I have. We'll share with you in a minute, the National Hepatitis Elimination Program, because that chain of centers already in place will not only help in elimination of hepatitis C, but will also be our future armor to combat something which is coming on to us just by putting a surveillance system on the ground, which we don't have at given time.
Right. So let's switch gears a bit and talk about. We're going to come back to this data because that is the topic mainly is artificial intelligence and its role in public health and clinical care. So let's talk a bit, bring that piece into the discussion, and then it's obviously connected to the data. We're going to come back to the data discussion. So in general, what are your thoughts about artificial intelligence in Pakistan for clinical care and public health? I'll start from there.
So, I think we all understand that in my lifetime and maybe in your lifetime, we have seen a couple of quantum leaps. One quantum leap was, we started with, when I went to Yale, that was the first time I ever saw a computer in my life, because that was back in '85. We didn't have any computers here. We had typewriters here. And worked with very rudimentary, they were very basic computers. Then the Apple came into the picture. IBM was the leader, etc., etc. So the computer became part of life. Then came the fast processors, data processing, etc., etc. Then came the smartphones. That was another big quantum leap, which has actually changed my and your life. Computer changed the life of that generation. Smartphones have changed our lives, and artificial intelligence is the third quantum leap that you and me are seeing in our lifetime, which is actually going to change the landscape 10, 20 years down the road. But artificial intelligence, again, is a double-edged sword. It's just like a knife. It could be a surgeon's knife, or it could be a criminal's knife. So
Okay.
it's a tool, and like any other tool, we have to be very, very aware of what the pros and cons are. We need to know how to use it, maybe how to regulate it at the regulation level. And you have seen that in the United States. They have brought the subject of discussion into Congress and Senate. And I think soon there will be some laws, because if you leave it unattended, I think it'll be an absolutely disaster, and maybe a tool of destruction than tool of construction down the road. So artificial intelligence is here to stay, number one. Number two, there's a big fear, which I don't sort of agree, that it will take away your job. I think that there's a big fear. I feel it's going to create more jobs. But the only thing is, the parameter of the job or the type of job may change, because at the end of the day, it's we humans which will still be dictating to AI what to do. So I think, the Google guy who resigned, Jeffrey Hinton, his main plea was that he could see the destructive side of especially the misinformation taking really strong roots without a regulatory mechanism in the United States. And that's why, he thought that, you know, this is a monster that he has created. And in his own words, that he said, unless I resign from Google, I can't speak about it. And so did he. So I think the point was well made, but I feel very strongly that I think it's a good technology. Number two, it's going to stay. Number three, it's a quantum leap. I think it will be very, 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 very good for humanity at large. And we'll come specifically to medicine in a minute. Uh, and it will really open avenues that have never been opened before. And it will actually add, but with a proviso that it should not be left like a uncontrolled gun laws in the United States. It should not fall into the hands of a National Rifle Association, et cetera, where you don't have any and laws, and then the poor schoolboy goes and kills hundreds of people without understanding why is he killing them. So it's a very dangerous tool, and I think very right early in the game, very strong regulatory mechanisms have to be in place, and specifically in medicine, where the privacy of patient is a very big issue. The confidentiality of the patient is a very big issue. Something like HIPAA laws, which protect the confidentiality of the patient. Something to that note has to be created by the lawmakers.
Right, I totally agree with you. And there is one question which just came to my mind, and I'm going to bring that to discussion. In the context of AI, many people talk about a lot of challenges, but one challenge. So let's see, the medical student who is getting into a medical college today is going to graduate maybe 5 years from now, and then he's going to specialize. I mean, when he practices as a clinician in the Pakistani market, 10 years down the line, what I envision that the practice of clinical medicine is totally going to change. My question is that, or my concern right now is that, are the medical regulatory organizations or regulatory bodies like PMDC, are they aware, are they cognizant of the challenges which the in practice? I mean, obviously, like let's assume, let me give you an analogy. Like the communication is not the way it was like 25 years back. The mobile phone, the email, everything has changed. So what I envision, definitely, it's not going to take the jobs, but I think you really rightly said the way the job is going to be done, that is going to be very different. But my concern is that the thousands and thousands of medical students and the medical professionals are not prepared for that, and there is nobody who is even thinking on these lines. Like, okay, in the AI world, where AI into the practice, into the clinical care, uh, are we preparing our next generation of doctors for that? What is your take on that?
No, we are not. And the reason is our leadership is totally unaware of what exists in the market. When I say our leadership, I mean both at legislative level. They are very unaware of it, as well as at the medical professional level. I think people are starting to wake up, especially in the medical profession. But and listen, we are not too far. When you go back to United States, back even 10 years ago, for example, the application, even now, the application of AI are still very, very limited. I mean, things are starting to evolve. So, when we say we are 50 years behind in such and such thing in space technology or whatever. So we are not really far behind. 10 years is nothing. So we will catch up in no time. But I think it's time like that. It's time to start to spread the word, create awareness, and that's exactly what we are doing today. That we need to be, if we want to stay in PKLI, being a center of excellence, is already started to work, and we'll share that with you in a minute, to see how we are going to incorporate AI into our clinical practice, into our preventive programs, into our diagnostics, etc.
Right. So let's switch gears to come back to data discussion, because now any AI. So let me share, Doc, Dr. Said. You must be already aware of this, but just for the education of the audience, uh, here's the thing: the any AI tool, the algorithm or the other things, the computational aspect of it, that is also important. You cannot undermine the importance of that and the effort of the people who make that algorithm or the front end or how that works. But the goal on which it is built, the basis on which that stands is the data, right? And I think, I mean, the more time so but the problem here is there are many problems with data in Pakistan. Right? There are problems like data, for example, privacy issues, for example, security issues, right? So having worked in the with government sectors or the semi-government sectors, what problems have you so far faced in like data in a private hospital, data in a semi-private hospital, semi-government hospital, or data in a government institution? So, what are the challenges that you have faced, and based on your experience?
Right. So basically, actually, I've never worked in a government hospital or semi-government hospital. PKLI is not a government hospital. It's a government-sponsored but completely privately run hospital. So the other hospital where I worked is Shifa International Hospital. By the time I left, they had a very rudimentary electronic medical record system. But since I still practice in USA for a couple of months, so I go back and forth, and all my training was on electronic medical records. So I'm very geared towards uh, what it takes to create a good electronic medical record system, and also what are the rules and regulations. This needs to be, see, this is not a like a free talk kind of a thing. It's a very responsible kind of a job, where when you're managing the data of the patients. And do you remember the other day there was a news that FBR, somebody hacked the computers of the FBR, and the data was leaked of all the guys who were whatever tax they were paying. So these risks are already always there. But whenever, at least when I think about creation of a EMR, um, it needs to be a very strong, foolproof EMR. Then it's not just the EMR; it's the person behind the gun. So people who are in the hospital, they need to be made very aware that you can't be just singing around that, oh, the such and such minister came to my hospital and we did a kidney transplant, for example, or such and such film star came to my hospital. It's not on in medical profession. This is a taboo to disclose anybody's identity, any patient's identity, or what kind of a medical problem that he came to see you with, because this is the confidentiality of the patient. So the whole team, for example, in PKLI, we train them that when you talk about EMR, because we are paperless, we know what the responsibility is. And even though there's no HIPAA law here, but we sort of follow our own HIPAA law to make sure that the confidentiality of the patient is not breached. Unfortunately, in the government systems, there's hardly any electronic medical record system. Even in the private system, a lot of even big name hospitals don't have a good electronic medical record system. And without electronic medical record system, you cannot, again, I repeat, you cannot build a good AI system, because AI is all data driven. And if you don't have a data on which you can rely to create whatever program you want to create, you're not going to do it. So just to give you an example, for example, University of San Francisco. So they have just signed a contract. I've been following them for last 10 years. And they have just signed a contract with NVIDIA. And NVIDIA is a big tech company which is making a very large capacity GPUs for them, so that they can store the data, do whatever they want to do. So similarly, when we talk about data in PKLI, we have a good storage system, cloud based, with all the precautions which need to be taken to protect your data.
Right. So there's another aspect of it. I mean, a lot of institutions have a lot of data, but though we, from an academic perspective, we researchers do repeat one mantra that garbage in is garbage out, right? But based on my experience, though it's not a lot of experience as compared to you, but I still feel that even a lot of senior researchers do not truly understand this true essence of it, because having worked in some of the leading institutes even recently, I'm not going to name those institutes, but okay, I see maybe some professionals or some very senior doctors claiming, coming from the US and working in these institutions, and claiming that we have maybe millions of data points and stuff like that, but we open that data and that is pure garbage. And I mean, like, no matter, I would prefer to have 10,000 data points which are actual
Clean.
data points rather than a garbage of 1 million
So
data points.
I
We
call
want
it clean data. And that's very, very important to capture clean data. And as you said yourself, the data is as good as you put it in. So garbage in, garbage out. And that's why,
yeah.
so when we were designing our program at PKLI, since I have worked with Cerner, I've worked with Epic, I've worked with Meditech, all these programs in USA. So we were very aware as an end user what to tell the company to build. And at that time, our request was that we put in how many cystoscopies I have done. So I will just type 52000, the CPT code, and all my cystoscopy from date to date, male to female, etc., etc. So this is, I think, when you design these things, the input of the end user, his experience, his exposure is very important. And say, for example, and this is my message to any other institution that does not have inside uh, people, it's worth spending the money to get the consultation from people who know the job, who can do the job for you. So if you're investing that kind of a money, you better find some good people to see what do we need actually. And obviously the safety issue, the security issues are very important, but also what do you want? So you don't get the good database, then it's a waste of time, waste of money. You'll not get good input.
Right. And then one last bit about the data, though there's a lot of discussions we can do about data, because, I mean, as I said, that for AI, like, the foundation is the data. Algorithm, that can be made. I do not want to undermine that word, but like any data scientist, that will work on the data. Now, there are two things when we talk about data at the level of an institution like PKLI. One is known as data governance framework. And then, for example, if PKLI wants to collaborate with the other institutions for the hepatitis prevention program, maybe that will be some government primary healthcare centers, or maybe other, as you said, that if you're making a system of data integration, that is, and then you have to have a data partnership framework as well, because it has to be something, a give and take mechanism, and what are the specifics of that give and take within that data partnership framework. So, and the point now, my question is that in Pakistan, like, these terminologies, the frameworks, like, okay, even those who are educated, those who are epidemiologists or public health professionals, they know some aspects of it, they know some quality issues of it, but you need to understand perspective from a framework perspective. Okay, like, at your institution you need to have a framework, a governance framework, and then you partner with other institution, you need to have a collaboration or partnership framework. So what do you want to speak to that?
Right. So I think it is extremely important that when you establish uh, your so let's rephrase something. I see that most of these big centers across the globe, Stanford, Harvard, they're actually changing the terminology. And now the term that you're using is digital health. Everybody is talking about, it's all under the auspices. So it used to be EMR at one time, but now I think we are gone. When we incorporate the AI, it becomes like a digital health. And a lot of big hospitals, Mayo Clinic, etc., they are creating this center of innovations in digital health. And all these center of innovations, the first thing that they create is they create a governance framework for that, because it is extremely important that, um, and it is no different. It is no different than you. then you plan your transplant policies, for example. It's no different than that you create your infection control policies for that reason. So it is very important that this so it is not just a computer that we are using and then putting some data, and that's what we are talking about. We are, again, as I said earlier, we are talking about creating a system of capturing clean data under a certain framework, under policies, under procedure, which not only um, ensures that we are capturing clean data, it also ensures that the sanctity of the data is right. Somebody is monitoring that, the built-in mechanisms, the security of data is there, the privacy of the data is there, and then you also have to devise a institutional policy that if you want to collaborate with somebody, what would be your framework of exchange of the data? What would you exchange, and under what contract you will exchange? Because and USA, this is a multi-billion-dollar business actually when you collaborate with other companies. So just to give you an example of how we did this, so we started this hepatitis C control program in 2016. We started to prepare for it. So we asked a company to create not a big wholesome data, but specifically that pertains to Hep C prevention. So this was called Hepatitis Prevention and Treatment Program. Then we also invited and the government at the primary health center. So they had so the Punjab government has two tiers of health governance. One is primary and secondary health, and one is tertiary and education. So we, as a PKLI, being a quaternary care hospital, we come as under that window. But health prevention, the primary and secondary health was the one that was dealing with the hepatitis C program. So we said, let's combine our forces together, and we gave them a lot of variables of what we were using in our centers so that they can benefit from what we were using. And then PITB, Punjab IT Board, sort of created a program for them. So they run their own program, we run our own program. We shared our data with each other. We mine our data with each other. We look at the statistics together as a collaborator with each other. And that brings the next question that I was talking earlier, and again, I will bring into the AI into that picture, is that now we have launched, when I say we, it's just not PKLI, it's a national hepatitis elimination program. And just to give a little idea to the audience, Pakistan, after Egypt, Egypt was number one country in the world that had the highest burden. About 8-9 years ago, their president issued a presidential decree that we have to eliminate hepatitis. He put all the resources into the picture. So what they did was, so the population of Egypt is about 110 million, something like Punjab population. So what they did was, in the first go, they screened entire nation from A to Z, north to south. They divided the country into 3 zones, and they screened them. So what they did was they would do a finger stick point of care test. Whoever was Hep C negative, he will be put out of the picture. Whoever the Hep C positive, they will immediately draw his blood, send it for PCR. Whoever was PCR positive, he will get the treatment. Whoever is a PCR negative, that means he was exposed but not infected. So he would. So now we are doing the same thing, but now we are incorporating artificial intelligence into this whole programming. And our artificial intelligence system, which is in the process of design right now, will actually, so say, for example, just to give you a rough number, so 100 people that we screen, about 10 will become point of care test positive. Out of those 10, 6 will be PCR positive. And then we are connecting this data to NADRA data bank, so that not a single soul is left and no
Hmm.
person is duplicated. So he comes to you and he gets registered in your center as a hepatitis C positive. Then
Hmm.
he comes to me, and so we count as him second or third person while he's only one person. So we are putting
Hmm.
all the and that's where the artificial intelligence comes into the picture, that it helps us. So for example, in 100, say for example, 100 million population, 90 will be screened and they will be clean. So then this 10 million population, sorry, I'm not talking about Punjab now, talking about whole Pakistan. So we are going to screen the entire population 12 years and older, and whatever that percentage is, so the computer or the AI program will immediately exclude, and the rest will start to generate the heat maps showing that this district is showing this prevalence, this district is showing this prevalence. And in that program, then we will just divide them into two. One would be the Hep C positive PCR, but normal liver function test, APRI score. They only require 3-month treatment. The second group would be Hep C PCR positive, but a very high APRI score, meaning by they already have a fibrosis or cirrhosis in the liver, which will probably require 6-month treatment. So if we start to do this manually, it'll be very, very difficult. But AI will immediately, we'll put our numbers, or we'll put our parameters, and AI will differentiate these patients for you. So at the end of the day, for me, it'll be a very clean data, it'll be very presentable data, and we will be able to tell the world that how we have incorporated AI into our health management program, and into the bed. And then 3 months down the road, so person who gets 3 months treatment, he will get an SVR to see his sustained viral response, to see if he's PCR negative, to make sure that, and we know the data tells us that using these direct acting antivirals, the cure rate is almost 98%. So we want to prove that, yes, we are achieving. So that will be another parameter that will be added into the AI that will declare the country hepatitis free down the road.
Right. So is it already getting implemented, or it's in the planning stage?
No,
And
so we just launched the program. When I say
yeah.
launched the program, it was a ceremonial launch by the last Prime Minister, Mr. Shehbaz Sharif. He was very kind,
Right.
and they put in 35 billion rupees in the budget.
Mm.
First time ever, such a huge amount put in. And in the first year budget, they had only put 500 million rupees. So I personally requested to the Prime Minister that, to make the world believe that we are serious, if we put only 500 million, people will think we are joking. So he was kind enough, and he put 7 billion in the first year's program. So we have a solid money block available for the launch of the program. So right now we are in the planning phase, and in next couple of weeks we have a very strong technical advisory group, that the group had been working on this for several years actually, but with a lot of technical input. They made the technical side. I try to buy in the political buy-in kind of a thing, and try to push it together. So now we are actually going to launch, and this is not a PKLI program. PKLI has just facilitated the launch of the program. It's a national program. It'll be done by the Ministry of Health, and it'll be done something like our COVID program, with a very strong monitoring, overseeing body that will make sure that a proper networks are created, dashboards are created, the data is presented maybe on a weekly basis to some very senior group of physicians and professionals and overseers. And then based on that, and as you understand, the health is not a federal subject anymore. So the provinces have to do this. So, but what we are trying to do is to create a single EMR and a single artificial intelligence based program linked through the NADRA database for the execution of the plan.
So the reason I asked that question is that this will be one of the one of the first public health programs in Pakistan, or maybe the first public health program in Pakistan, which will be using artificial intelligence. And I will be interested in learning about the real world lessons learned from that. So maybe
Sure.
we can follow up on that in this way, because I think it's that information is also going to be gold, because obviously you're going to go to the field, you're going to learn something. Everything is not going to turn out the way you thought, and then
Right.
it's going to be an iteration. So that information put down to public health professionals, that will also be gold. Maybe we can collaborate later on and see if somebody we can
Right.
once you have some.
Across the globe, this is very normal. When you launch such massive programs,
Yeah.
it's not like every house is an air-conditioned house, and every So there'll be a lot of modifications, there'll be a lot of upgradations, there'll be a lot of changes in the philosophies, just to give you an idea. And we have learned a lot of lessons at PKLI already, so we are already loaded with a lot of information and data that what would be the challenges. And here again, that's why I want the state to get involved, because with their in our hepatitis program, when we were running it, a lot of time we had to involve the deputy commissioner or the commissioner to give us the security and administrative help, actually. So this is not going to be easy, but
This is not
needs
going
to
to
be
be
done.
easy. Yeah. Yeah. So one thing which you kind of alluded to it, and it's also on my list of questions, and I think it was actually the next question in my list, and that is collaboration. Okay, there's a lot of collaboration within the institution. There's a lot of collaboration outside the institution, but one thing is that that collaboration is within the public health or the doctors community or the medical institution. Now, when you're talking about AI, then you have to collaborate with data scientists as well. Now, here is the problem. Traditionally, uh, uh, I don't know about other countries, but in Pakistan, my experience is that we have not been able to create an environment where engineers come together with doctors. They work on joint projects and come up with novel solutions. But in AI, you definitely have to do that. For example, LUMS, Lahore University of Management Scientists, has to collaborate with some medical university, and in the same way. So, have you any experience of doing that,
Right. So,
yeah, or
when I started the PKLI back in 2018, my
hmm,
first stop, even before launching PKLI, that we went
hmm,
to LUMS, and we visited
right,
their basic science lab, and they have beautiful basic science lab, and we had almost signed the MOU with LUMS that we'll give you the clinical data, you will do the basic research with us. And same was true, because we did not, at that time we had a very small rudimentary public health department. We had like maybe 3 epidemiologists and a couple of biostatisticians. So we wanted their IT department and their uh, data science department to sort of work with us. So remember, the whole word is collaboration. I would say that, and that is something very much missing in Pakistan. Unfortunately, we don't have the culture. As I said earlier, the basic scientist doesn't talk to the clinical scientist. The clinical scientist doesn't talk to the basic scientist. So the result is that we have never been able to make our own stuff. We don't know what genes we have, what kind of expressions of different genes we have, why we have such an aggressive bladder tumor in Pakistan compared to what I see in United States, for example. So there must be something wrong, and somebody has to do research right at the basic level to come up with those answers. Why is it that 80% of the people will clear up the virus and 20% will not? What's the difference in their gene? What's the difference in their food habits? Somebody has to come up with the local answers. I mean, I can't just rely on US data or European data. So this is what we are here for. And again, your point is well made, that the field of data science is very, very primitive in Pakistan. There aren't many educated people in the field. There are institutions lack data miners, data scientists, data analysts. Um, and as I said earlier to you, I was just not too long ago, I was in San Francisco at a meeting, and the whole crux of the meeting was data is the future currency. Data is the future currency. I mean, everything is data. I mean, why on earth Google is a multi-billion-dollar company? Just because of the data. They have the data. So I feel very strongly, and I suggested this to our prime minister also, and he's very keen that they'll do something about it. But I feel that and then data. And the other thing that I think we should also mention is tech. We are very, very poor towards the technology. I mean, in America, people who are in early 20s are multi-millionaires because they have come up with some tech-based idea, and the society supports it. There are a lot of incubators. They get funded, and then they uh, and again, one of the use of the AI, again coming back to our original question. See, I think for people who are not very much into the AI, it's important for them to understand that AI is nothing but the set of data that sort of the bigger the pool of the data that you have, the repetition, and then the machine learns uh, large language. And now I think the concept is evolving that just foundation models are not good enough. The medical acquired languages are coming into the picture, both which are based on free text, or I think it's called Foundation EMR, and the other concept is based on like the coded things. Like, for example, if I want to do a cystoscopy, my code is 52000. I can pull that. But now I think more and more, and similarly, I'm sure you're familiar with Mimic. So, at Beth Israel Deaconess Hospital, they put in, I think it's close to 40,000 patients' data that they have de-identified. So their secrecy but they made it public. And Mimic 3, and now they're going to Mimic 4, has one of the largest data pool that is available to public, actually. A lot of EMRs, especially the private hospitals, would not allow you to use their data. But I was just going through some numbers. In USA, there are 84 different medical uh, data sets which are coming up. Some of them are for public use, some of them they would not allow them to free access. So this is actually an evolving field, and I think everybody in that world is talking about, please regulate it so that we take it in a more organized fashion.
Right. I think we are also getting out of time, so I'm going to run into the remaining questions a bit quickly. So there are a couple of things. One is that, for example, you talked about your system getting based on the NADRA record. Now let's now this you someone may argue that it's a discussion for downstream, but I think one has to think for the downstream problems before, right from the beginning. For those individuals who are not registered in NADRA, and some of the maybe, for example, Afghan refugees, or maybe anybody, whoever is not registered with NADRA for any reason, what is your plan for them? Because
Right.
they are going to
So,
contribute to data
right.
spread.
Yeah. And not only that, we have factored that in our own population, and a lot of rural population does not have ID cards. So
Okay.
we are going to develop a unique identifier number for them, uh,
Okay.
which will not be their ID card number, but
Okay.
that number will be only applicable to that person. So no matter where that guy goes, through his name and date of birth and father's name and that unique identifier number, you'll be able to trace him. So we are trying to create a foolproof mechanism, and obviously the bulk of our data will be derived from NADRA, but maybe 5, 10% I would say would be these unique identifier numbers that be given to the people.
Right. So the next question, you talked a bit about the regulatory bodies, and I think this will be perhaps our last question, because we have already run out of time. And before asking this question, I'm really thankful to Dr. Saeed Akhter for giving us time for this session. So you talked about the regulatory bodies, and even I have to communicate. As part of this question, I have to communicate that recently I was the part of one of the project with Duke University and one of the Pakistani university. There was a collaborative project, and the scope of that collaborative project to suggest regulatory frameworks for the developed countries and for the developing countries. So, I mean, bringing that context is that even in the US, there is a lot of confusion, and the confusion is like this. For example, if you're there's a machine learning model that is predicting maybe some lethal condition, and a doctor acts on that condition, and if there are some legal repercussions of that, who is going to be responsible? There's so many questions that are unanswered, right? And same is there for the developed countries. And then because we have a different background of a lot of things, including the clinical care for the developed and the developing countries. So what do you suggest to the regulatory bodies? From where should we start? Should there be a separate AI regulatory body, or should that be integrated into? Should that be taken up by somebody, maybe like CPSP or PMDC, or what do you suggest about that?
I think the medical regulatory body should be totally separate, because as you know, in AI there's a whole world of AI that deals with robotics, for example, robotic surgery, for example, smart prosthesis, for example, a blind's eye, for example. So that's a whole world of AI, which is different in terms of medical products and whatnot. So I think medical AI needs to be regulated by doctors through, and probably PMDC would be the CPSP is not the right forum because they are more like taking exam and whatnot.
Yeah.
PMDC is the regulator, and they should look into it. And I think I will bring it to the attention of the president of but I think even before the PMDC, it needs to be discussed at the Senate and Assembly level, National Assembly level, or maybe provincial assembly level.
Right, but at the same time, Dr. Said, if I mean, people are needed to be sensitized about that. I'm assuming that okay, you will discuss a lot of things. I mean, for example, they might have heard a lot of things about economics, like other fields about which they get problems. They might have some sensitivity. They might have some education for them. For example, okay, they might know about some of the concepts about it, but I think even before bringing that to anybody, whether that is a PMDC, that is Senate or any other regulatory bodies. But my reservation is that there has to be some level of sensitization for all of these leaders. What do you think?
I agree with you, and like what we are doing today is a sensitization session. And similarly,
Yeah.
when the PKLI starts this AI program, and we are actually going to build AI in our nursing curriculum. By the way, we are putting that into our School of Nursing, School of Paramedics. There will be whole modules of AI that we are going to teach these kids. Actually, we are starting that not too far from now. So eventually, what will happen is that it's a new product in the market. Like any new product, you have to just introduce that into market. It's not going to be like buzzword in next 5 years here. Maybe it'll take 10, 15 years. And I think that slow process will give us enough time to look into it. And then we also watch what the West is doing, what the bad side of it is. We don't have to reinvent wheel in a lot of aspects, so we can learn the good, bad, and the ugly from a lot of historical data, actually.
Right. And there are two things which I want to bring into, maybe take your quick input on that. One thing is that when we talked about AI, you're generating a lot of data. And obviously, we discussed a lot that any AI cannot be without generation of the data and generating quality data. And then another piece of the puzzle is like developing a lot of skill set, maybe like programmers, maybe data scientists. So both of them can, if you think of that from a business perspective, that is $1 billion. I mean, what I'm trying to say is that if you bring a case to the leadership right now, Pakistan is going through a lot of financial problems as well, and I think this can be a one area which can bring a lot of
Revenue.
well deserved revenue to our sector. Because I want to bring one conversation which I had with my advisor at Carnegie Mellon University, and he said I had a capstone project about databases in developed countries, and he specifically said that if you work on something quality databases for developed countries, I mean the developed world is going to jump into that. So what is your take on that?
And that is one of the biggest thing that I've had in my mind as a scientist and as a researcher, that for PKLI we need to generate a lot of sources of revenue, so we are not dependent on the state grant for that. And these are some of the ideas that we have, not only just uh, developing a lot of text. I mean, there's a lot of technology. For example, if we can develop a good EMR, which is a very user friendly, easy to manage. I mean, it's a multi-billion-dollar industry actually.
Exactly.
Similarly,
Yes.
how the dictation systems, the electronic medical records are being dictated, the dictaphones, the smart voice. So, I mean, the tech is, and that's why I was telling you earlier that young kids making millions of dollars, Pakistan can make billions of dollars if our leaders sort of put their heads together, if somebody educates them, that where, and I think I have a sense that they have fairly good understanding of things. But it's just a matter of how to put it all on the ground in a very practicable fashion.
So, Dr. Saeed Akhter, thanks a lot for your time. Before we call this session off, is there anything that you want to say to our audience as a
Uh,
concluding remark?
uh, uh, I think the only thing I want to say is that the data is future currency. We need to capture the future currency. We need to do it so that we uplift our country. We do it so that we uplift the quality of care. We do it so we create systems. We do it so that we enter the 21st century. We do it because we owe it to our kids and the new generation that what will be, what is there to come. And I think if we miss the boat, it will be very tragic. The opportunities are endless. There's a tremendous amount of money involved, even in these clinical trials. Apart from the artificial, and then we are going to put artificial intelligence in the clinical trials also. So when you do these things as a planned approach, and then you bring the right people who understand what the job requires to do the job, not just some novice, then things have to move forward. And again, I'm not saying that it will happen overnight. It will take its own time, but we have to start somewhere.
Definitely. Thanks again, Dr. Saeed Akhter, and thanks again to everybody who has been with us till now. Take care, and we will keep bringing such content to you, and give us your feedback in the comments. Allah Hafiz and bye for the time being.
Thank you so much. Appreciate it. Assalamu alaikum.